Okay, so we're going to go ahead and get started here. If you haven't seen any of our webinars, we have other ones recorded on our YouTube channel. You can see those as well. And we are definitely working on increasing our quantity of our extra content. So let's go ahead and get started. So this is our Everything Psychiatric webinar, everything regarding psych and everything crazy, right? So I have crazy glasses, crazy patients, maybe, maybe not. So my name is Kendall Wyatt. I'm the instructional content strategist here at Picmonic. What do? I pretty much kind of am the owner of all of our content. I make sure that everything is medically accurate as far as a student's standpoint, and I work as our liaison between our students and our actual content. I help write our content as part of our scholar team, and I kind of always work on improving it and making it better and listening to what you guys have to say. I am started out as a paramedic. I am also an RN, registered nurse, and I am in my third year of medical school doing my medical school rotations here in the Phoenix Valley. We're broadcasting to you live from Tempe, Arizona in the Phoenix Valley, where it is a beautiful 72 degrees, 75 degrees, maybe 78 degrees. But the point is, it's getting cold everywhere else, and it's becoming amazing here. So definitely not in a hot box like you have probably seen before. We're in our sound booth where we record all of our Picmonics if you use our Picmonic system. So what is Picmonic is the question. And Picmonic is great. So what we do is we take all of the stuff you need to know in nursing school, and we turn it into crazy fun characters. We love creating these characters, and they turn into things like bipolar. We're going to talk about bipolar patients today, and we turn it into a bipolar bear. And that way you can remember all the signs and symptoms, treatments and whatnot for that using characters. So if you have maybe warfarin, we have warfarin, you know that that's a drug that's anticoagulant, you need to monitor PT-INR. And we'll show you a warfarin, this warfarin character with a PT-INR factory. But you'll need to also memorize, or know and make sure you know that heparin is another anticoagulant. Well, we show a hippie heron, which is a heron is a bird, and dressed as a hippie, and then we'll show you a PTT hourglass so that you know you want to monitor PT in the drug heparin. So it's all kinds of different things. We have all the different stuff you need to know in nursing school. Over 700 topics. I think we have over 750 now at last count. And I need to update my slide with the new information. So everything you need to know, all of those things of knowing which one's up, which one's down, Addison's disease, Cushing's disease, all those things that you have to memorize, we've got it by far. So today we're going to go over webinar and go over concepts. So what are we going to cover today? What are we going to cover? We are going to cover the psychiatric system. This is definitely not kind of the normal flow of our normal webinars. What we're going to go, we're going to talk about mood disorders, personality disorders, anxiety disorders, eating disorders, and then some pharmacology. And we're going to mix in pharmacology as we go through. So it's kind of not the normal structure of learning everything together. We're going to go over how you can pull this together and really kind of understand what you need to know for your psych exams. Because a lot of psych is really just knowing which one's which, knowing the differences of them and what really stands out, and that's what we're going to go over. So mood disorder-wise, we're going to talk about depression and suicide, of course, bipolar disorder, schizophrenia, and we're going to mention but not talk as much of schizoaffective and schizoid, and definitely knowing the difference. So the very first thing is depression. So it's actually really common to have depression because there aren't that many criteria to really say that you are clinically depressed. And one of the things is anhedonia. So just a general anhedonia. Anytime you see an, that means without. So without, hedonia is enjoyment. Without enjoyment of things, what a person would normally enjoy, what they used to enjoy. So maybe they used to enjoy going out to a ball game, whatever, or they used to enjoy eating Fritos, and now they don't enjoy that anymore, and that's anhedonia. They don't enjoy things that should be normally enjoyable or they used to enjoy, and they see weight changes, sleep changes, fatigue. The big thing is trouble concentrating and feelings of worthlessness. And inside of Picmonic, we always show a depressed emo, and to classify as depression is very interesting. You only have to have these characteristics for 2 weeks. That's definitely not really that long of a time period for sure. So what do you see? What do we know is the first line, almost always the first line agent for depression? What is the medication that we would be talking about? In case you've not been on our webinars before, you can type into the question box. So for all of my crazy answers, if you know, right away. So Nichelle says Xanax, and that is absolutely what everyone wants. That's what they request, but that is absolutely the last one we give them. Xanax is alprazolam. So it is an important point here to make sure that you don't try to memorize trade names. You're not going to get trade names on the NCLEX or your exams anymore. Trade names are phased out. So Xanax, you would never be given. You would be given alprazolam, which is the generic version. And alprazolam, why would we not give it? Well, it's an insanely addictive drug, and people want it, and it's definitely something that's on the it's definitely something that has a lot of risk for abuse, as well as CNS depression, because it's a benzodiazepine. So other options, and I see lots of different ones in here, some of them are the right answer, and one of those is we have to give an antidepressant, yes, and that's an SSRI. SSRIs are selective serotonin reuptake inhibitors. So we'll get to drugs here in just a second. But let's talk about it. Here's our actual depression assessment Picmonic, and this one's an interesting one because you have decreased energy. We've got our decreased energy bunny, and you'll see you see fatigue, but you also see decreased libido. And this limbo pole, decreased libido, decreased interest, and slowed CNS function in this slowed, gummed up brain. And it's definitely kind of gives you the persona of depression. Along with depression is always a risk of suicide, right? Always a risk of suicide. And who is actually at risk at suicide? If I said, who would you say is the most at risk for suicide right now, who would you pick? If you had to pick a group of people or, a class or classification, what would you say? What kind of people? Katie says those with guns. Okay, well, we're not going to get into that debate. That's an entire debate that we don't want to get into. Okay, so I see lots of the right answers, and the best thing is who is at most at risk for suicide. It's actually the extremes of age, and the extremes of age, which lots of you put in, so teenagers, and then of course the elderly and adolescents. Now, the number one indicator of somebody who might actually attempt suicide is somebody who's tried it before, and that's what I see all the time with these types of questions is you always think of the obvious choice, but sometimes you miss it on a lot of questions. So somebody who's tried suicide before should definitely be taken seriously that they're going to try it again, and that's somebody who definitely you should perk your eyes up. And of course then teenagers, males before females, and then of course elderly. We're seeing a lot more elder suicides. Definitely something that I did not enjoy going on. You go on I worked EMS for several years, and we went on several scenes where there was a self-inflicted gunshot wound of an elderly person, because they often sometimes give up and feel isolated as well, for sure. So people who are depressed and whatnot. Now, when we talk about this, let's see if I've got this in my, so here are our suicide Picmonics and what we have. So we have an assessment Picmonic, and we have our risk factors Picmonic. So risk factors, of course, as you can see in here, are the extremes of age, access, drug abuse, people who use drugs, people, men more than women, and whatnot. And let me tell you what, here's an interesting thing. Here's what you need to think about when you have somebody. What do you need to assess? Or assess as far as suicide, and it seems pretty easy after you hear it, but most often people don't always get the right answer. And what that is that when we have somebody who is at risk at suicide, you need to find out three basic things. And what are those three things? Well, you need to find out they want to kill themselves, so you need to find out if they have a plan. Do you have a plan? Are you suicidal? Okay. Do you have a plan? So if they have a plan, that's the next step to being serious. And if their plan, what do we worry about if they have a plan? If we know that they have a plan, they say, I'm going to go home and I'm going to take a bunch of Xanax. Okay, so we talked about alprazolam. I've got a plan. I'm going to go home and take a bunch of Xanax and never wake up. Well, next thing we would do is, this sounds very straightforward, but we would ask, do you have any Xanax at home? Do you have the means? So you are suicidal. Do you have a plan, and do you have the means to carry out that plan? Somebody who's going to shoot themselves, if they don't own a gun, then they don't have the means. Now, that doesn't mean they can't go get one, but that is, if they own a gun, that would definitely put them at very high risk for suicide if they did have the means to carry out their plan. Somebody who's going to jump off a bridge, and there are no bridges around, definitely is not necessarily at risk. And that's how we get, into determining whether patients are need to be committed and whatnot. Different topic at hand. So that's definitely something to think about, and always to know. So with this, we talked about antidepressants. So we're coming back, circling back around to SSRIs, selective serotonin reuptake inhibitors, and that's kind of the first line treatment for depression. And there's some really important things with SSRIs. If you're depressed, and I give you an SSRI, why is it such a high yield point that they have an increased risk for suicide? If I gave you an antidepressant because you were depressed, why are you now at increased risk for suicide? It seems just like it doesn't make sense. Why? I mean, what is the plan? Ahmed, you're doing great today. And that is, he said it right away. And the thing of it is because when you excuse me, I got a hiccup or something today. So a patient who they start an antidepressant, they used to be completely paralyzed by this depression, or down in the dumps and not able to leave their home, but now they have energy and they're feeling a little bit better. And sometimes when they get that little bit of increase, they actually have the energy to carry out their plan and then essentially kill themselves. And that's why we would watch them, or we would be aware of this increased risk for suicide. Definitely something that we have to worry about. And the other important thing with almost every antidepressant is that they have a delayed onset. So as a nurse or as a practitioner, we're going to tell them that this medication may not take effect right away. It's not going to take effect immediately. So all the time I have patients come in, especially when I was doing my family medicine rotations or their psych rotations, they started on an antidepressant, and they come back and I'm just not feeling very good. I've been taking it for 2 weeks, and we know that we have to give them 3 to 4 weeks until it reaches this therapeutic effect and increases the serotonin levels in their brain, so that they then, of course, can then become, can rid themselves of depression. Of course, there's lots of other things as well. So the other thing, just a side note here of serotonin syndrome, and it's definitely an important point just to kind of be aware of. Serotonin, I always think of it as like this, it's the thing that makes you happy. It makes you feel better. It increases your mood. And if you have way too much serotonin, then everything's going to be elevated, everything possible. And that includes you're going to be wide awake. You're not going to be able to sleep. You're going to have increased temperature, hypothermia. Your heart rate's going to be beating really fast. You're going to have things coming out at both ends at an increased rate. That's nausea, diarrhea. You're going to have myoclonus, shivering, and you're just going to be everything on racing, and that's a sign of serotonin syndrome. Increased blood pressure, hypertension, and whatnot. Serotonin syndrome. If you had too much serotonin, sometimes we see this if you have an MAOI, and MAOI. What type of food consumption do we worry about with that? What's a really important point to know with that? What do we worry about? MAOIs. This is a big one. MAOI. We have an MAOI. That's right. Roxine, really good. Avoid tyramine. Tyramine, aged foods. And I love, actually, lots of you guys, I skipped over. Lots of you guys said tyramine. Yeah, right away. Tyramine with the MAOIs causes this hypertension and these kind of effects. And what happens is you see this in aged foods. So tyramine is in aged foods. Aged foods like wine. Love a good wine. Aged foods like cheese, aged cheeses. My lovely example of pickled pig's feet. Anything pickled and aged in a jar is typically high in tyramine for sure. So definitely something to remember. So we're going to speed up a little bit and go through. Here's lots and lots of different antidepressant Picmonics. So definitely ones we're talking about here. So we're talking about, and I forgot to actually mention, you need to know the endings for SSRIs. So endings of SSRIs are etine, and we show our little zitty team with this 5-HT, which is the sign for serotonin reuptake controller here. So also we have SNRIs, which is selective norepinephrine reuptake inhibitors. And does anybody know an example of an SNRI? SNRI, selective norepinephrine reuptake inhibitor. This is a fun one. I have the Picmonic here. I also just skipped ahead way in my slides. I hate when I do that. Seems like I do it every single time, at least once. So it's one of them is bupropion. So our butt propane here. So our butt propane is bupropion. So that's a really important one for sure. Oh, and venlafaxine, Katie says, that's also a really important one. Selective SNRI as well. So we're going to talk about OCD and some more mood type disorders as we are going, and one of those is OCD, obsessive compulsive disorder. And one thing you always need to remember here is OCD is different from OCPD. An obsessive compulsive personality disorder, that's what I have, and that's I don't think it's a bad thing. I think it's great to be obsessive compulsive personality, and that means you're very driven, and I always pick the best points, but it's different from OCD. OCD is obsessive compulsive disorder, and this involves it's kind of hard to explain, but there's a couple really common examples you're going to see on your exams. So it's somebody, OCD is somebody who obsesses over something. So they obsess over the fact that they are not going to that they're going to leave their doors unlocked at their house, that they've left the doors unlocked, or that they're going to leave their home and leave their doors unlocked, and that's an obsession. So what happens is it drives them compulsively to lock and relock their doors before they leave their house, and maybe they have to do it, and they count a number of times so that they make sure that they locked it. And this isn't normally a problem until when? When it interferes with their daily functioning, and that's typically measured at about an hour a day. So for 59 minutes you can lock and unlock your doors, but if it's more than an hour is what you need to think of, or if it interferes with your daily functioning, you're late for work every day, you get fired from your job because you were always late because you have to lock and relock your doors, then it is essentially a problem. The most common example is being having the fear that your hands are covered in germs. So you're obsessively you have this obsession that you're constantly getting germs on your hands, which you are. Everyone is. Your hands are nasty, and if you're OCD right now, you should go and wash your hands. They are covered in germs. But there's a compulsion that you absolutely must constantly wash your hands to get all those germs off. And every time you touch something or you are going around, you have to just keep washing your hands, keep washing your hands, keep washing your hands to get all the germs off. Reality is you can't get all the germs off. There's tons of germs. So I'm sorry. What's the treatment? SSRIs. And this is something that's kind of a first-line treatment for OCD is SSRIs. It's to give them this antidepressant so that they know, so that they can treat OCD. It's kind of a one you're very likely to see, and to be able to understand that it's usually not until it interferes with their daily functioning. Before I jump to bipolar disorder, I always tell this story. One of my best friends actually, he has an obsession that he is going to be stranded when he leaves his house in his vehicle or wherever without water. I don't know if something happened. I never have been able to get to the bottom of it, but before he leaves his home, every time, or if he leaves any place, he will chug water. And I know, because I've watched him, he is counting this period of time in his mind of how long he's drinking, and that's how he gets over his obsession, is with that compulsive drinking. So he just has to do it. If he gets interrupted, he starts over, and you see this all the time in a lot of patients. They'll come in and explain these types of behaviors, and they just can't control it, and they would probably need an SSRI, or there are some other treatments and whatnot. So bipolar disorder. Bipolar disorder is a really fun, good time, right? That's what I always tell everybody. Bipolar disorder is described as bipolar, right? You are lots of ups and lots of downs, bipolar. And we have our bipolar bear to help you remember that it's two directions. We have one mean and one excited bear head, and the other one's always a sad bear head. So what is bipolar characterized? And it's just mania. What does mania mean? You see this on an exam, and it means excessive, elated mood, these people, you will characteristically see a bipolar patient who they are normal or doing okay, and then they have these periods of time which last more than 1 week where they can't sleep. They are writing letters to every member of Congress for some purpose that doesn't make any sense, and they are not sleeping, and they are just, oh my God, over the top, and they very often seek out these pleasure-seeking activities. And what are those? Well, you see them seeking out prostitutes. You see them seeking out sexual pleasures. You see them doing drugs, and you see them doing, most commonly, the example you see are excessive purchases. These people go out and, very classically, 1 week period of time, this person's going out and they are making tons of purchases. They've maxed out all their credit cards, and they have bought all kinds of stuff, and they've done it for a week, and that's mania. If they don't have the extreme elated mood, there's something called hypomania, which is not as excessive as well, and you could have bipolar. There's different classifications which are kind of beyond the scope of RN, and that's hypomania. So that's definitely bipolar. Now, what is the number one drug that we think about when I say bipolar? What do you know we're probably going to treat it with? What's the one that's a big commonly tested one? I've decided that it must be the sound booth that gives me hiccups. Every single time I get in this sound booth and I try to do a webinar, or even just record an audio, I start getting hiccups. So I think I've decided today that it's definitely the webinar, or the sound booth, sorry. So what's the drug? Oh, everyone typed in the right answer, and that was lithium. That's what I was looking for. So what do we know about lithium? I mean, lithium, it's an element on the periodic table. Good for you. Congratulations. What do we need to know about it for nursing? Well, the number one thing, we don't really know the mechanism of action for it. That's fine. It's a mood stabilizer drug. Now, that's pretty easy to remember how it works, right? Because you give it for bipolar, or this up and down mood. The number one thing couple of things that you just absolutely have to remember for NCLEX, I'm trying to keep this to a minimum, is that it has it has a very narrow therapeutic effect. So what does that mean? It means it's a very small window where you can have way too much or not enough to where it works the best. So we know we need to monitor levels. And the other really important thing is that we can't give lithium to anybody who's pregnant. Some drugs, most drugs have all these classifications for pregnancy. Lithium is a category X, which absolutely not contraindicated. You cannot give it because it causes something called Epstein's anomaly, which is a tricuspid valve abnormality in the heart of a newborn when they're developing. It's definitely not something that's good. So schizophrenia. So schizophrenia is definitely something that you see lots and lots of. What type of hallucinations? What type of hallucinations are classic with schizophrenia that you're going to see right away? Auditory hallucinations. That's right. That's definitely something. Lots of you guys say that example right away. Auditory hallucinations are classic of schizophrenia. If I had a patient who has tactile hallucinations, what would I suspect? Does anybody know? That's another really kind of a common one that you see with something. Tactile hallucinations? If I had a patient that had tactile hallucinations, I would probably go in the possibility of something like cocaine. That's definitely something where we see a lot of tactile hallucinations. Bugs under your skin. That's right. So back to schizophrenia here. The big thing is DSM-5 changed the types of schizophrenia. So if you have an older book and you saw the different classifications of schizophrenia, you don't need to get caught up on so much of those classifications because they've changed with DSM-5. The great news is that means almost all of the testing resources also have swayed away from really pushing in on those types of schizophrenia. So they're going to ask you things like, auditory hallucinations, and what? Negative and positive symptoms. And this is where this is what you're going to see. Negative and positive symptoms. So if I have negative symptoms of schizophrenia, positive symptoms, how are you so easily able to tell the difference? So positive symptoms are things, if I took a normal person and I elated them and I added to them, those are positive symptoms. So positive symptoms would be increases of things like excitability or increasing things. Negative symptoms would be bringing a person down. So the best example would be flat affect. And if I used to be able to do this really well, but a flat affect. What's a flat affect? You see somebody with a flat affect, and that's essentially flat affect. This is a flat affect. They show no emotion whatsoever. Whereas you see me, I have lots of crazy emotions with my face, and I use lots of emotions. But if I had a flat affect, I would definitely not really speak well or use much emotion. And that's a flat affect. That's really a classic classic negative symptom. You see it also with depression, but definitely a really common negative symptom. Right? So we have several Picmonics on schizophrenia to help you keep these positive symptoms and negative symptoms definitely separated, and to be able to go through them all and understand what they are with all the characters. And I love our little character here with Sketchy Fern. So we have this little Sketchy Fern guy to help you remember schizophrenia. And we use this throughout. One of the things that's really important, along with schizophrenia, is to know the antipsychotics. And this is definitely something that I see lots and lots of people, lots of students struggle with. And I want to just show you some basics on antipsychotics. And with antipsychotics, there are first-generation antipsychotics. And these, anytime you see these drugs and it's called a first-generation drug, what you should immediately be thinking about is it's an older drug. It's not only an older drug, it probably requires a larger quantity of the drug to take effect, and it most likely has a lot more side effects. Almost always a first generation of whatever it is had more side effects, and it took a larger dose of it to take effect. Almost always, especially with antipsychotics. You also see this with antihistamines and whatnot. A good example, the best example I can explain here to give to everyone should be able to relate to. First generation antihistamines and second generation antihistamines. A first generation antihistamine is diphenhydramine or Benadryl. Benadryl makes everyone sleepy, right? Why, yes, it does. People take Benadryl to go to sleep. Don't recommend that, of course. But Benadryl makes you sleepy. Benadryl actually is one of the most common overdosed on drugs. So Benadryl makes you sleepy. Definitely has this really crazy side effect everyone gets. But second generation antihistamines are like cetirizine, Zyrtec, loratadine. Loratadine is Claritin. I think it's Claritin. I try not to get too stuck up on the trade names, but those definitely do not cause sedation. Those don't make you sleepy. They're better drugs. They're newer drugs. So let's look at antipsychotics. Exactly the same thing. First generation antipsychotics. There are high potency ones and low potency ones, and then there are second generation antipsychotics, which are often called atypicals as well. So here's just a better example of how we have these broken down. So high potency, first generation antipsychotics, you should immediately think of which one, haloperidol or haloperidol. That is the classic, the go-to, definitely the classic go-to example of the first generation high potency antipsychotic. And what are the symptoms that you're going to see with haloperidol use? You're going to see what are the symptoms? You're going to see a large number of what types of side effects? You're going to see EPS side effects. I see that. Adele definitely said EPS, extrapyramidal symptoms. You're going to see these, and we're going to go over these and how you can see the presentation of them. You have a very high chance of these. There's also fluphenazine as well, which is a high potency first generation. Definitely lots and lots of side effects. So as we go down, let's think about this. How do we just easily remember? Well, haloperidol, it's Haldol, right? Been around for years. You heard about people getting Haldol, haloperidol 30, 40 years ago, or however long, a long time. before I was born. Long time ago, definitely a first-generation drug. Fluphenazine is another first-generation high-potency one as well. A low-potency one is chlorpromazine. Chlorpromazine, definitely another, but it's low potency, so it's not as potent. So it may take a larger dose, or it may not work as well. But it also just isn't as it doesn't have as many side effects, but it's not as potent. So we have chlorpromazine. So another interesting thing, low potency. It's low potency, but what's another use for chlorpromazine? Does anybody know another one of chlorpromazine? Chlorpromazine. What do we? It's a psychotic. What's another use for it? Sometimes just take it for a good weekend, right? This is actually not in our Picmonic as well, and I plan on adding it to our fact. And I didn't even realize it wasn't in there. I must have missed it when we went through and made this Picmonic. But chlorpromazine's trade name is actually Thorazine, and it's actually very commonly given for hiccups. It's another kind of a side use of this antipsychotic. It's given for hiccups. So you'll see people given Thorazine. So just a side note, not a really high yield point for NCLEX at all, but just a fun, everyone likes to have fun high yield points for your friends, right? Yeah, yes, of course. So second generation atypical antipsychotics. So those include clozapine, aripiprazole, and risperidone. So as soon as I say clozapine, you should immediately, in a second, not only say clozapine, because that's our Picmonic from our product, but you should immediately be screaming at the screen, what side effect with clozapine? Do we give people clozapine first? I mean, we could give them clozapine. It's a second generation atypical. It does technically have a less of a risk of extrapyramidal symptoms, but what do we worry about? Adele, yeah, we worry about weight gain, but number one right away, Sarah said it, is agranulocytosis. You absolutely will not, you will not walk into any exam, a psych exam, and not remember that clozapine, you must monitor white blood cell count. You must monitor cell counts weekly. Absolutely must with this medication. It will. It's not a maybe. It will decrease white blood cell count in your patients. The thing of it is you have to monitor it and adjust the dose based on that, or stop the dose if they have a severe neutropenia from taking the medication. It does work. It's an amazingly effective drug, but it does have that side effect that everyone gets for sure. So aripiprazole and risperidone, those are other atypicals. They have less chance of side effects of extrapyramidal symptoms for sure. And risperidone is one we use really commonly nowadays. It's called Risperdal, and is the trade name. It's a really common drug. So let's talk about, this is the most important, probably the most important slide I think in the entire presentation that I can give you today. It's definitely the one that you will learn the most from, and it will help you the most, because it's probably the one you're going to get the most questions from, because you can memorize all of these drugs, especially, they all cause EPS symptoms, right? All of those antipsychotics. It's just a fact of, whether you're taking an increased dose or for how long. Well, here's where you need to remember. So number one thing is dystonia. These are all side effects. So let's talk about this. You need to know what the side effect is, what actually happens. I'm going to demonstrate it for you. Then you need to know when it's going to happen. And less importantly, you need to know what to do. And why do I say less importantly? Well, less importantly because all you need to know is what it is, and then what to do, whether it's serious or whether it's something that you would not worry about, which we're going to worry about all of them, of course. But the first one is dystonia. So dystonia, when you see D, that means abnormal, and dystonia. So we see dystonia. It means muscle spasms, or it's also called torticollis. And this one specifically, dystonia, muscle spasms. I like to call it. There was a commercial for a while called taco neck syndrome, where you had your taco neck, and you were going to eat your taco, torticollis for your taco neck or your dystonia, and it's a severe muscle spasm. And these severe muscle spasms, this torticollis, and we've depicted this here as our little our coal character in this hourglass, torticollis. And but here we are. We got taco neck syndrome. And if you have taco neck syndrome, that's torticollis. There you are. So imagine yourself, you're eating your taco. Well, when does this happen? Well, you're going to get taco neck syndrome or torticollis, dystonia, within just a few hours or a couple of days of starting to take your antipsychotic. Is this a big deal? Not really. I mean, I love to eat tacos. I mean, I think tacos are delicious, as long as they're not too spicy, because the side effect, of course. We're not going to go into that. But I love tacos, and I think the having taco neck syndrome is definitely worth taking to have. So what do? Well, we give a patient benzotropine rather, or trihexyphenidyl, or Benadryl, diphenhydramine, and that manages it gives an anti-muscarinic effect, and it just manages with the drug. So you'll have these patients that come in with muscle spasms, and they're just given benzotropine, and benzotropine is trade name Cogentin. You see that definitely these people are on antipsychotic, and they're just automatically given that as well, or they're started on it as a while. So not that big of a deal. Not something you really have to worry about. Just crazy muscle spasm. Now, what happens next if they're taking antipsychotic is my favorite one. I love this word. So it's called akathisias. Akathisias. So what happens with akathisias? So you're taking this antipsychotic. It's the next thing that happens. So you got your taco neck syndrome, and you're okay with that. No big deal. But what happens if taco neck syndrome and then you have some ants in your pants or akathisias? That's not good. No one likes to have ants in their pants. I mean, and you see right here, here's our ants in the pants guy. Akathisias are basically this unexplained restlessness. I mean, these people are just like, they're constantly just, they can't, they just got to keep moving, and they don't know you just feel like they just constantly have to keep moving. And, it's because they feel like they have these ants in their pants all the time. What do? Well, these patients cannot take these medications any longer. They have to be switched to a medication with less extrapyramidal side effects, like an atypical. But this happens after weeks of use, usually 4 to 6 weeks. You see these kind of symptoms. The patient comes in. So patients who are taking antipsychotics or started on antipsychotics, I mean, they're watched very closely, and definitely because of all of these crazy risks of side effects. But personally, I think the side effects are worth it. I mean, I love tacos. I think taco neck syndrome is fine, or dystonia, or torticollis. But what I don't think is okay is ants in the pants. But what I don't like more than anything is crazy people running around. So I think the side effects are fine. So akathisias, we're going to use an atypical. Now the next one is a really important one. And this is, we have a whole Picmonic on tardive dyskinesia. And when does tardive dyskinesia happen? Tardive dyskinesia, we have a TAR dive, diving into TAR character. And what happens is, it happens after 6 months of use, usually 6 months, long-term use of these antipsychotics. So what's happened is these patients have probably had akathisias, and we missed it, or they've, I saw a patient when I was doing my clinicals for nursing. I was in a VA, and this patient had been in there for a very long time, and he had tardive dyskinesia, but unfortunately, they had already stopped his antipsychotic and put him on atypical. But what did he present with? And the number one thing you're going to see on your exam is this perioral movements. So you're going to see these people doing this. And they're going to be lip smacking, right? They're going to be moving their head and neck all the time. It's almost like they have Tourette's. But what do we know about tardive dyskinesia? Very often, a lot of these effects are not reversible. I mean, that is definitely something. This lip smacking, this head and trunk movements, they may be permanent, and definitely something that you have to immediately alert, because you have to stop this medication right away and use an atypical antipsychotic. But very often these effects are irreversible, and that's important to know as well. But these patients should have most likely presented with akathisias ahead of time to give you this kind of heads up that, hey, this patient's going to have some side effects. So the next one, and why we worry the most, is what's called neuroleptic malignant syndrome. Neuroleptic malignant syndrome, NMS. I mean, we hear about this all the time. It's all over your psych, everything, right? What does that mean? I mean, we have our neuron leopard guy here with our malignant man. But what does it actually mean? Well, neuroleptic malignant syndrome can happen anytime. It can happen pretty much anytime when you're taking an antipsychotic. Typically, probably going to happen very early on, or if it's a very high dose of an antipsychotic. But what happens? When you hear malignant, you should know that that's bad, right? I mean, if you have cancer that's malignant, that's a no-no. That's not good. We got to get rid of it. If you hear malignant hypertension, that's severe hypertension. And if I tell you neuroleptic malignant syndrome, that's severe neuroleptic, right? That's bad neuroleptic syndrome. And that's exactly right. These people have severe muscle rigidity. They tense up all over. Their entire body tenses up, and not just a spasm. Their entire body, they are like stiff as a board. That's a common wording you're going to hear. Their blood pressure is going to be through the roof, and most importantly is that they have this insane fever, hyperpyrexia. So what happens? Well, when you have this severe muscle rigidity, I mean, anytime the muscles just clamp down really hard like that, you have an increased build of tension and temperature, which causes hyperpyrexia. And you have to give these people dantrolene. Now, what happens? The mechanism I'm not going to go into, but where is another scenario where you see something very similar to this, and the solution is giving dantrolene? And this is important, especially for nurses and everyone, really, all healthcare providers. Where's another scenario where we would give dantrolene? Anybody know? Ah, right. Lots of you guys got it right away. That's great. And the answer here is malignant hyperthermia. So again, malignant, very bad hyperthermia, and that happens usually as a side effect of anesthesia. So you always ask patients, very important that you do a pre-operative interview, and you're asking them, hey, have you ever had any reactions to paralytics? And that happens, they become stiff as a board, but they're paralyzed, so you can't tell. You can only see that their temperature is rising, their blood pressure is rising, and you have to give dantrolene. Very similar, and these are all emergencies, definitely, for sure. So as you can see, here are all of the examples again, and we can go through them to see right away. We have our taco neck syndrome, dystonia. We have our akathisias coming on in weeks. Get my little animations to catch up here. And then we have our tardive dyskinesia coming on within usually 6 months, and then neuroleptic malignancy coming in at any time. And that's the most thing you need to know about all of your antipsychotics. If you've got that down, you're pretty much well on your way, because it should be pretty clear whether it's schizophrenia or bipolar, as well. So just a couple things on anxiety disorders. I'm not going to spend a lot of time on these, but definitely panic and anxiety, these are important. So let's just quickly touch base on these as well. So Sarah, who helps me make these animations sometimes, she really loves the jokes, and post-traumatic stress disorder, why would they do that? I still don't really get that, but I'm assuming because it's wood, but whatever, she thinks it's hilarious, and I'm sure she is just laughing so hard right now, and it's fine. I make corny jokes. Sometimes I just laugh to myself. So anxiety, anxiety disorder. What do we know about anxiety? What is something that is important? We know there are levels. So what about mild anxiety? This is our anxiety assessment. We know that there are different levels of anxiety. One thing you should know right away is that mild anxiety is a good thing. Mild anxiety is amazing. It increases your alertness. It's good for tests. It makes you pay attention. It increases everything. You're wide awake. You're good to go. Moderate helps as well, but gives you a little bit decreased attention span. And then severe and panic then inhibits your abilities. In panic, you are completely useless and unable to cope and whatnot. So remember that mild anxiety is a good thing, and that's definitely an important point. Post-traumatic stress disorder, PTSD. One thing with these particular patients is they've had some kind of stressor in their life, and the most important thing is that they relive it or they have flashbacks. It's definitely something that counseling and whatnot for sure helps with. So not something I want to go into in detail with just for the sake of time. So anxiety, I asked this earlier. What is our treatment for anxiety? Severe anxiety. This is something that's missed all the time. So, for anybody who pick a benzodiazepine like alprazolam, Xanax, or Valium right away, I don't blame you, but just make sure you don't miss it again. So you can miss it with me, and I don't mind. I won't give you too much of a hard time. But know that we pretty much give SSRIs first line, because most people have an underlying depression or underlying issue that's probably causing them this anxiety. We can give them therapy, and then as a last effect, benzodiazepines. Why do we worry about benzodiazepines? I mean, tolerance, but Yeah, addiction as well. But what is a side effect of benzodiazepines aside from addiction? What's a side effect of benzodiazepines? Benzodiazepines are alprazolam, Xanax, lorazepam, Ativan, or diazepam, which is Valium. Victoria said it right away, and that's definitely CNS depression and yeah, lowering mental function. That's right. The other thing that's important, so it decreases, causes, it makes you numb, which is maybe a good thing if you want to be numb. That's why people seek these out in addiction. But more importantly is it requires a higher dose. You build up tolerance. So maybe you start out on 2 milligrams of Ativan every day, and then in 3 months, you need 4 milligrams. You need a higher dose to cause the same effect. And then you get dependent on it because you're on such a high dose of this benzodiazepine. So these are not short, long-term medications. They're not indicated for it. Yes, I know your cousin Melinda has been on Valium for years. Good for her. But that's not what we teach and not the plan of what we're supposed to be doing for sure. Definitely not indicated for that. So what if we have a patient who's an alcoholic or they have an addiction history? We're going to give them buspirone. Buspirone, this one's interesting. We have a bus pirate in Picmonic for help you remember. It's okay for addiction patients, but in reality, it requires a pretty high dose to work. So I personally, I think it gives more of a placebo effect than it really does an actual effect. But we do prescribe this pretty often. We see it pretty often. It's a non-addictive choice of medication. So that's definitely really kind of it for anxiety disorders. Now, personality disorders. We have tons of personality purses in our Picmonic learning system. So you can go in and learn all these personality purse disorders or personality disorders. And you know what's interesting about these is you really just need to know the main points about each one. The main points. Because you don't really need to know a lot of the treatments. Pretty much what they're going to do is give you one of these scenarios and ask you which one it is, or what do you suspect that it is, or kind of that scenario. There's not a whole lot. So number one, you just really need to memorize a lot of those key points with each of the personality disorders. So here are 6 of the personality disorders, and I just want to instantly just mention a couple really high yield points. They're going to let you just sneak right in on each one of these. So as soon as I say narcissistic personality disorder, this person, a narcissist, right, or somebody with narcissistic personality disorder, what do you see right away with these people? These people, typically the scenario you're going to see them with is somebody who gets angered anytime they're questioned, or somebody who doesn't want to wait, or the classic example here is somebody who is in line at the doctor's office or waiting in the room for the doctor, and they are absolutely in a hurry. They cannot wait any longer, and they are storming out. And this is somebody who is not waited very long. Keep in mind, there's been some, I know, pretty long waits happen in reality as well. So those are definitely something that you see in there. We have all the other details as well. Obsessive compulsive personality disorder. These people are perfectionists. I mean, and they accept nothing but perfection, and that's it. And I definitely can sympathize with OCPDs, obsessive compulsive personality disorder. They are perfectionists. They want everything to be done exactly the same way every time, and they want it to be perfect. And that's definitely, as much as I hate to admit that I have anything wrong with me, it's definitely a lot of quality that I have, for sure. You see a lot of very high functioning people are actually obsessive compulsive personality disorder, because they're very much perfectionists. So the next one is dependent personality disorder. And here's our little dependent man in the diapers. What do we worry about dependence? These people cannot do anything without. They can't do anything on their own. Oh, Natalia said she definitely nurses a lot of OCPD. Yes, you see a lot of doctors and nurses that are OCPD for sure, especially ones that have been doing it for a while. Yeah, so for sure, that's right. So dependent personality disorder. What do we see this? These are people who cannot do anything by themselves. They cannot start anything new without it. You see this a lot in relationships. You see one person is dependent on the other one, not just financially, but emotionally, everything. They do everything. Not in a controlling sense, but they can't be alone, or they can't function by themselves. That's a dependent type personality. Seems pretty obvious. Histrionic. We show our little his purse here. This one's just fun. I think of histrionic and I think hysterical. Why do I think hysterical? Because these people make me giggle. This is somebody who goes way above and beyond, and they are flashy and they are loving it. They often, they, as much as I hate to say it, it's very often women, and these people are going to, this scenario is just somebody who comes in and they are just all about showing off. They're very flashy. They wear very bright colors. I always like to use the example of my bright green glasses. Like they would wear big, giant, everything, and it would just be all in your face. And, they may be very provocative. They may be, they may show off themselves in a very sexual way, and definitely trying to, kind of show off is a not just show off, but be very flamboyant is a good example. So histrionic, I always think of hysterical because they just make me laugh every time I've seen them. Definitely over the top, right, Katie? Way over the top. These people are just theatrical for sure, and that is actually one of the terms, theatrical. So kind of a pretty classic one. Borderline. This one's actually probably the most important one for nursing wise, and that's because borderline personality is very often misdiagnosed, but there's a couple really key terms we see here, and the one is we see borderline personality disorder very often. We see this characteristic. It's called splitting. And what is splitting? Well, I either love you, and I love you, and I love you. You're the best person ever, and that's just amazing. And you're my best good friend. You see this in psych facilities. They try to butter you up, and they're trying to be your buddy, and then you don't give them an extra dose of pain medicine, and you're dead to me. You're dead to me. Now you are dead to me. I don't want to talk to you. I hate you. You're the worst person on the planet. I always like to explain this kind of as like a teenager, right? You have a teenage daughter, and she just loves you, butters you up, and then you don't give her whatever, and she hates you, and you're dead. Splitting. That's kind of a, that doesn't mean teenagers have splitting when they're all borderline. Maybe they are. I think all teenagers are probably crazy, but it's definitely somebody. You see these people often have an inability to have a relationship. Their relationships are never very long because they fall in love all at once. They're in love. I mean, I have this girlfriend, this boyfriend. They're the best girlfriend and boyfriend ever. How long have you been dating? 2 days. We're going to get married. We're going to have 400 kids. We're going to buy a house by the lake, and everything's wonderful. And then they have an argument, and they're dead. They hate them. They're the worst person ever. Splitting. Pretty easy. So, Diane says for histrionic, so like Nicki Minaj. I don't know if I would say that, but another, definitely like, what's her name who wore a bunch of meat? Lady Gaga. So that's definitely, I think that's more for a, that is a show. But if you saw a regular person walking down the street that way, and doing those kind of crazy things, absolutely, you'll see that for sure. So, avoidant personality is the last one, and these people, that's pretty obvious. They have just this social withdrawal. They avoid everything, and it's definitely the way you see it. They're withdrawn and whatnot. So the next thing, and I love this one, are eating disorders. So eating disorders is something that is missed all the time. We just have a couple more slides to go over here, and we're going to be finished up because we're about to our time limit. But definitely eating disorders. This one is very, very common, especially on the NCLEX and your nursing exams, and it is missed all the time. So there's bulimia and there's anorexia. So we have both Picmonics on both of these. But here's what everyone always misses. And I mean, I get people on this question so often that I almost feel like I'm just wording the question wrong, but it's just everyone always gets it wrong. And what is it? Well, what's the difference? So anorexics starve themselves, right? They don't eat at all. That's correct. We see these people most commonly with a BMI of less than 17. That's a diagnostic criteria. Now, somebody who doesn't eat, has a low BMI. What do we see? What else do we see aside from that? So we see fatigue. There's a couple classic ones I really want to get. We often see this in girls. We see this often in teenage girls. Why do we see it? Well, they find that they can't, in very controlling scenarios or controlling home environments, because they can't control their home environment, but one thing they can control is their food. So they control that, and then they don't eat it. So they find this. Hair loss is another great example, Heather. And one of the ones that I see really often as very high yield is amenorrhea. They don't have a menstrual cycle. Why do they not have a menstrual cycle? Well, this makes pretty good sense when you think about it. Their body doesn't have, it's starving. It doesn't have anything. So does their body want to get pregnant and have to feed a baby? No, because it would just have to abort the baby and you would have a miscarriage. That is absolutely what would happen. You don't have enough nutrients to take care of yourself, so you don't have a menstrual cycle. It stops because you were not able to take care of you're not able to provide enough nutrients for the baby. You see this exact same thing in a lot of athletes. So athletes who work out in a very, they're very healthy and or ripped or muscular, and they work out excessive amounts, their bodies are being worked very hard. So because they're being worked very hard, their body stops very often. These women, of course, stop having a menstrual cycle because they can't. Their body thinks that it has to work and run 12 miles a day, so it wouldn't want to try to also feed for a baby. So that's kind of the underlying concept behind it. And that's where you have to think about concepts. So bulimia, here's where everybody always misses it. What's the difference? So bulimics throw up, right? The answer is no. They don't always have to throw up. What they do is binge and purge. And so here's the scenario that you must understand with bulimia nervosa. Anorexics just don't eat at all. They starve themselves. Bulimics, they go and they eat and they binge. And they eat 14 In-N-Out burgers. I only had one today, but they would eat a whole bunch. I don't know if you could actually eat 14, but they would eat 3 or 4 or 5, whatever. They would eat a bunch. And they'd eat fries and they'd have a milkshake and they're just loving life. And then comes the purging part. So they may vomit. That is one mechanism. But what happens is that they actually then they do something to stop eating, or they either stop eating or they use laxatives to get rid of everything, to purge. I don't know, I was thinking of a good politically correct word for, crap themselves. That wasn't a cuss word, so I had to pause. They binge and then they purge. So they may starve themselves. They may go several days without eating, but they binged on all this food and then they stopped eating, or they may take laxatives. They may vomit. They may vomit the food back up, and they may have that eroded enamel that you see. Classic question. But very often a bulimic may have a normal weight. They may absolutely have a completely normal weight. So they binge and purge, and Ahmed said it a good example. They purge it the other way, and that is exactly what happened. They either purge it up through their mouth or they purge it out the other end, or they just stop eating. So they binge and then they stop, and they do something that is to stop them from eating or gaining weight at that point, so that they can maintain a normal weight or be underweight. So we have Picmonics on bulimia and anorexia as well, and the big thing is there are lots of controversial things regarding feedings and whatnot, but you may in fact force feeding a patient and in this type of scenario. So the last thing I want to talk about, and very important, I'm going to speed through this, is substance abuse, and I'm just going to spend just a few minutes because I know I'm hitting my time here on trying to keep it nice and concise. You absolutely must know every single one of these substance abuse. You absolutely must know every single one of the reversal agents. No exceptions. You must. You must be able to identify what's different in each one of these, and you absolutely must be able to identify how you would treat it or what to do. And these are pretty easy. We have Picmonics for all of them. We have Picmonics for all of the reversal agents. We have Picmonics for every single one of the assessments. So let's just look at a couple of these. Here's our marijuana intoxication assessment. Somebody who uses a lot of marijuana is going to have a conjunctival injection. Very common term that I saw when I was studying. What does that mean? A conjunctival injection is just red eyes. But they're not going to tell you red eyes. That gives it away. They're going to say this patient has a conjunctival injection, and they're hungry. They like to eat a lot. They have anxiety because they're always depressed. These people sleep a lot. They're slow going. They're CNS depressed, right? Alcohol abuse. Somebody who abuses alcohol. These people are also CNS depressed. And you see them definitely having a lot of, it's a depressant, so decreased libido. We have liver problems, all these things. But what do we see? One thing is alcohol withdrawal. So we have to understand that if you are abusing the drug, you are under the effects. So you need to know what the effect of the drug is. So if I have marijuana, it's going to slow me down. If I have alcohol, it's going to slow me down. If I have benzodiazepines, it's going to slow me down. So what happens if I take a bunch every day and then I just stop all at once? The exact opposite happens, right? This is exactly how you need to think of this. You need to understand whether these people are what the scenario that you're being presented with, whether you're being presented with everything being up, 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 or everything being down, down, down. So if I'm giving a patient who is has lots of anxiety and they're just all up in arms, they may be actually withdrawing from something that is a depressant. So they may be withdrawing from benzodiazepines or alcohol or marijuana. So that's why we see seizures, and we will put somebody who's on alcohol withdrawal on seizure precautions. It's called CWAP protocol. It's something we give them, something to calm them down because you have this paradoxical effect. So definitely something you just have to understand the concept behind it. So marijuana slows you down. These people don't have a lot of energy, but if they stop, they have this paradoxical reaction. Alcohol, same way. Opioids, somebody who has opioid abuse. So if I take opioids, what am I going to see? We have our little poppy droid here. I'm going to have euphoria. I'm going to have pupillary constriction, meiosis. So just an important point, and just something you need to know, just as to save you some time. Meiosis. What's the difference between meiosis and mydriasis? How are you easily able to tell that one is pupillary constriction, one is pupillary dilation? Well, the easiest answer here is that pupillary, which word is larger? Mydriasis, right? Mydriasis is the longer word, which means dilation. Meiosis is the shorter word, which means constriction. Don't let those two mix you up. Or you can just remember our mice eyes here, mice eyes for meiosis with our little tiny pupillary constriction inside of Picmonic. The most important thing you absolutely must know, especially with everything that's in the news and all this stuff that's going on, what is the reversal agent for opioid abuse? What is that reversal agent? You've got to know it. This needs to be at the tip of your tongue, and you should just immediately shout this out. And you don't say the trade name. I said it. You guys already typed in the trade name. The trade name's not going to be on your NCLEX. The trade name's not going to be there. So the trade name is not good for you. You will miss questions, especially because some of the trade names sound like other drugs. You should always learn. And when you get to clinic, I understand you're going to be told a lot of the trade names. But if you're pre-exam and pre-licensure, you don't need to worry about it. And the answer here is naloxone. And here is our Picmonic for it, right here. And you see this nail. You see these giant nails, nail locks? Naloxone. Because every time, and I love tricking people with this, the other one is naltrexone. Naltrexone is also an opioid antagonist, but it's a long-term one that we use a lot for smoking cessation, and but not a reversal agent for sure. So naloxone. So let's move on down here to the bottom. Benzodiazepines. We know that I already asked you that these slow things, they cause CNS depression. They make you sleepy. They make you lethargic. I mean, it's a fun time on a Saturday afternoon. If you have a lot of benzos, a lot of Xanax, what is it? A Xanibar, I think is the term. They used to, maybe they still do, I don't know, but they used to come in these little bars for alprazolam. It used to be like a big street thing. I used to work EMS, so I would always be seeing patients overdosed on all these fun terms. If you work EMS, you learn all the street drugs. Definitely a downer. What is the reversal agent for benzodiazepines? This is another one you must know, and it's so easy. We got it right here in our Picmonic. If you know the Picmonic and you've learned it, then the answer is right here for you. Benzodiazepines like diazepam, lorazepam, alprazolam, all these wonderful Saturday night drugs that everyone loves to abuse. What's the reversal agent? Flumazenil, right? Mario right away, flumazenil. And we have a flute-based nail right here, flumazenil. Flumazenil reverses benzodiazepines. You must know these. These are so important. You've got to know these reversal agents. So that's really, really important to know what the actual reversal drugs are for these particular overdose type scenarios. So a patient who takes a lot of benzodiazepines and stops cold turkey, these patients are going to be very hyper agitated and very awake, and they're going to have lots of problems. They're going to be hypertensive. They're going to be tachypnic for sure, and very irritated. So let's look at cocaine. Everyone, cocaine's a good time. I've never used cocaine, of course, but I'm sure it is a good time. I hear all of my patients used to tell me all about how it's so much fun. We have our little cocaine character here. Steve's giving me a bunch of crap on Skype, but because I'm talking about drugs. But we see here's our hallucination character, right, for cocaine, our Halloween. What do we see with cocaine? So we see tactile hallucinations pretty often. These people are very alert, euphoric. They're very hypertensive. And one thing you see with very important with a lot of excessive cocaine use is that they have a very high increased temperature. So they're very hyperpyrexic and very hypertensive. And if they snort cocaine, you see that deviated nasal septum. That's kind of a clue-in point that somebody's been snorting something for sure. So yeah. So the last one here is amphetamines. We have several more just in these 6. We have phencyclidine, PCP, and a couple others inside of our Picmonic system, but not ones that we're going to go over today. But here's amphetamines. Amphetamines, definitely something you see with meth, but also you see with Adderall. You hear patients taking amphetamine salts, Adderall. You see a lot of common scenarios with this. And what is it? It's a stimulant. And we give Adderall as a stimulant, as a drug as well. But if you snorted it or you took too much, you could have amphetamine intoxication, or you do meth. And these patients could be anorexic because it's a stimulant. It stops you from eating. They often lose a lot of weight. These patients are very hypertensive, tachycardic. They're up, they're amped up, and definitely they don't sleep. So it's definitely something that just hypes you up for sure. And that's definitely something you have to watch for. You see people using methamphetamines right away. So here are some more toxicities and reversal agents. This is the last thing in our webinar today, and this is just kind of going back over. So here's some substances and reversal agents. There are lots of these that we have inside of Picmonic, but here are just some ones. We talked about opioids and naloxone. We talked about benzodiazepines and flumazenil. But what do you do for amphetamines? Well, there is no reversal agent. The answer is really just to acidify the urine, because what happens is when you have an acidic urine, that causes a very basic thing like amphetamines, a basic substance, to be excreted from the body faster. So if you anyway, I'm not going to go into those details. It's a little awkward. But another one we see very often is acetaminophen, and this is something that probably the worst possible way to overdose. What is a normal amount of acetaminophen that you can take in one day, in 24 hours? Normal amount. Right away. Lots of you right away. 4 grams or 4,000 milligrams. Definitely do not want to take any more than that because of the risk of fulminant liver failure. So if you had a patient that overdosed on acetaminophen, this is also why we don't want to give too much things like painkillers that include Tylenol in them. Even though it's a synergistic effect, you can only have so much Tylenol per day. So 4,000 milligrams or 4 grams. What do we know? So we can give you what drug could we give you if you acutely overdosed? The answer is N-acetylcysteine. And what happens is, the mechanism is not as important for nursing, but just so you know, there's the system of glutathione that allows you to detoxify and get rid of acetaminophen. And if you take too much acetaminophen, you don't have enough glutathione to kind of process all of this Tylenol. And what happens is N-acetylcysteine replenishes that glutathione. And several of you just typed in mucomist. And N-acetylcysteine, the trade name is Mucomist, but Mucomist is not going to be on your NCLEX. What might be on your NCLEX, though, is that what is very classic of this N-acetylcysteine. What is something that I know before I'm half a hallway down, I know somebody's getting some N-acetylcysteine or Mucomist. Ah, that's right, Stephanie. It smells like rotten eggs. If it's nebulized, it smells like rotten eggs. It really does too. It's disgusting. Oops. So here we go. So just here to show you that we have over 30 different toxicity Picmonics and reversal agents. Maybe you needed to remember, and just important, here's some quick ones to help you remember. Beta blockers. You'd have too much beta blockers. What's a reversal agent? Well, it's gluking Kong right here, or glucagon. All these are really important to you to really kind of have in your back pocket to know what these toxicity and reversal agent Picmonics are. So you need to know over here, here's warfarin, right? You need to know warfarin. Warfarin is very important. What's a reversal agent for warfarin? Well, if you overdosed on warfarin, I can give you vitamin K, but vitamin K takes a long time to act. What's faster? I can give you fresh flows in plasma. So both of these are inside of our Picmonic. Here's our opioid or our poppy droid. You have both our both options in here, which is our nail locks and our nail T-Rex, to show that those are both indicated for toxicity. Here's our Benz dice, and here's our flute mace nail in here for flumazenil. All those in there for you. We have tons and tons of those in there as well. For sure. Oh, Samantha says there are new guidelines as less than 3 grams at 24 hours. That is, there's a lot of big push to actually have to minimize the amount of acetaminophen. That is true, and I don't know that they've really changed for sure the guidelines, but I'll double check. But it's definitely a push to have the absolute minimum amount of acetaminophen daily. It's definitely always been a plan to push that number down. And one thing that's important is if I take 3 grams of or 4 grams of acetaminophen, Tylenol, that works on my liver. What drug works on my kidneys? What's the other drug for pain that works on my kidneys? Metabolized by my kidneys, maybe is a better way to put it. You should know these things, and that is ibuprofen or NSAIDs, right? NSAIDs work on the kidneys. So a patient in liver failure, you would give them ibuprofen. A patient in kidney failure, you would give them acetaminophen. So here's just a quick review, sorry, because I've definitely went over time. But the big thing is to be able to identify what's the difference in the disorder, really know what the treatments are, know what you're monitoring, know the gist of what the treatments are, and then know what to expect. So what are you going to watch for once you have a treatment? You are going to watch, lithium. You're going to have neurotherapeutics. So you got to watch and monitor the levels. You have a patient on clozapine. You got to monitor white blood cell counts. Those are all the things. You're not going to be given, especially in the nursing level, which one are you going to give, those types of scenarios, but you're definitely going to have to know what to watch for, and that is the most important thing. And with substance abuse, you are going to have to be able to identify what the substance is, what they've possibly overdosed on, and what they should be given or what we should be using to treat them. That's really important. That's definitely an important point to make sure you know. And know those reversal agents, all of them, especially opioids. And, there's all kinds of them in Picmonic. It's so easy to memorize, go through those. Definitely what we have. We have webinars every week. You can always go to our website, picmonic.com, for picmonic.com/webinars and see all of our webinars, or click on resources on our website. So if you have any questions, you can ask now. But definitely, Stephanie says, yay, for sure. Adam asks if I brought my dog, and he's actually laying here beside me on the floor. But come here, Stitch. I don't think he wants to get up today. If you have any questions, now is a good time to type them in the question box. Oh, come here, Stitch. Oh, okay, there we are. So Stitch needs a haircut, but this is Stitch. He likes to come with me pretty much all the time. He's my right-hand man, and he's kind of tired today. I don't know what his deal is. But if you have any questions, you can type them there in the question box. Stitch? I don't know. He's not having quite a good day. He was sleeping in the back. So Sarah asks, why do I have blue lights behind me? So Sarah, I'm actually broadcasting from our Picmonic sound booth. This is where we record all of our audios for all of our products inside of Picmonic, and because of we have to have lights that are LED, we use these LED rope lights. And I use a different light when I'm doing webinars, but we have to have a special one that doesn't emit, we can't have any kind of incandescent lights or fluorescent lights because they cause audio interruptions. And our headbanger team, which is the team who creates a lot of our, who has a creation team here at Picmonic, they like these blue mood lights because they enjoy them. So, Katie asks about liver failure. Is it from acetaminophen? Is it centrilobular? And I am 99% sure that it is centrilobular, without looking it up. But yeah, it's definitely beyond the scope of nursing. But it is definitely centrilobular. Yeah, pretty sure, because it's fulminant liver failure, which would be centrilobular for sure. Roxanne says it was her first time attending a Picmonic webinar. It's very helpful. So Roxanne, one of the things I all the time, and someone always asks in the beginning. I don't know if it's because there's not a lot of time, and you guys have to go, and sometimes I always go over my time, which I apologize. But we record these. We have on-demand ones at you can go to picmonic.com and click on resources. We have ones that are on our YouTube channel recorded. I definitely recommend watching our pharmacology one. We have one on ECGs, which is one of my favorite topics, heart failure. Some of these are some of our best topics. We have an obstetrics one coming up in a few weeks. Reproductive coming up in a few weeks, pediatrics, which is always a fun time, and we'll have to get some children in here to use as some examples for sure. But definitely glad to have you here, and you can check out the recorded ones. We always put these up a couple of days afterwards, and check out our other ones. Sign up for definitely for other webinars. Carolina says she loved it. I'm currently in mental health, and it's going to help me out for this upcoming exam. That's good. So what I definitely recommend is going in. We have something in our app called Pathways. You can go in and see all of the Picmonics organized out by all of the subject areas, and you should definitely go in and review those, because what I like to do in the webinars is not teach you everything, but hit on the most important points. And then you can go back, and sometimes I get tongue-tied and twisted and excited, I don't know, but you can go in and actually see all of the signs and symptoms for schizophrenia. You can see the interventions lined out for schizophrenia and bipolar and all of those nitty-gritty details that you absolutely have to know, and it's going to help you get all those select all that apply questions correct. I'm really just definitely hitting the highest yield points, so definitely for sure. I'm just kind of making sure you don't get any of the high-end ones. Let's see here. Oh, here's a question. Heather says, how many hours should we use Picmonic for NCLEX prep? So we have an NCLEX study guide. You can go to picmonic.com/NCLEX, or you can just Google NCLEX study plan, and we're at the first result. But we have a study plan that's designed to help you study for the NCLEX it's for a 4-week plan. And that's about 4 hours a day of doing question banks and Picmonic, going through our entire Picmonic library so that you can get up to speed and learn them all. It really depends on where you are. What I see very often is I always ask people, there's 3 problems that students have when you come to preparing for NCLEX. You either have a knowledge deficit and you don't know the material, right? You don't remember all of the pieces, so you don't remember what the reversal agents are, right? That's one. You have a knowledge deficit. That's where you need to go in and you need to learn. You need Picmonic. You've got to go and learn the Picmonics multiple times until you've got them down. Second part is actually applying the knowledge, critical thinking. You know, your nurse critical thinking cap, and that's where you have to practice questions. And you practice questions. We have a free question of the day you can always use, and we have some video blogs we have coming out to help you do that as well. But you should have a question bank, and I ask people where they are. So if you did well in your courses, you did great in your school courses, you did amazing, and then probably you just need to review for several weeks of maybe, going through and learning all the Picmonics, which will take you several weeks, and you're going to brush up for, usually 4 to 8 weeks to really brush up and go through things. What we recommend, the best way to use Picmonic is to use it during your coursework, to use it during your studies, during your psych course, and then when you get to NCLEX time, you're just reviewing. You're not trying to use us as an NCLEX review resource, because that's not what we're designed for. We will help you, but your best way to get you immediately know is definitely doing it, kind of learning everything during your courses as you go through. But if you're reviewing, then you definitely need to go through and spend, usually takes anywhere from 3 to 8 weeks, we see, as far as several hours a day going through and learning all the Picmonics. Looks like Heather says she's been a LPN for 11 years, so I've learned everything the wrong way. I can tell you from an absolute certainty that as a paramedic beforehand, I learned everything a lot of the wrong way too before I went to nursing school. And you just have to really practice questions to get yourself into that groove. So that's where you kind of have to go. So get yourself lots and lots of practice questions, and as you miss something, review the Picmonic on the topic to find out why you missed it, and be honest with yourself. Is it because you're not answering the questions right? Is it because you are, just you lack the knowledge, you know, you just don't know, you forgot it. You've got them mixed up, or you didn't know which one to do first. Do not apply your real world scenarios. NCLEX is a perfect little world where you have everything in your back pocket. So that's definitely something you can think. You can reach out to us. Guys, if you have any other questions, lots of you still here, you can reach out to us at feedback@picmonic.com. And if you have any other questions. But other than that, as always, we are glad to have you in, and you can check our other webinars out. You can reach out to us and request webinars. Sign up for a one next week. I think it's next week. But we will see you soon, and as always, good luck studying. Have a good night.